Welcome to Real World Endo. This is Ali Nasseh with a presentation on the role of ultrasonics and endodontics. I'm often asked the question, what has been the most significant addition to my endodontic armamentarium over the past couple of decades? Now, this seems like a reasonable question, and while the addition of night-eye rotary instruments, apex locators, digital radiography, bioceramics, negative pressure irrigation, as well as a number of other techniques and devices have been very helpful to my clinical practice as an endodontist, the addition of piezoelectric ultrasonics has been the single technological breakthrough that has had vast clinical application spanning all the way from non-surgical treatment and retreatment all the way to surgical endodontics. Now, rarely you can find a technology with such wide range of applications. And in that respect, ultrasonic devices, unlike any other devices in clinical practice, are not unitaskers. Now, ultrasonic devices, more specifically the piezoelectric units, have greatly improved the efficiency and the efficacy of care in endodontics. Now, before I demonstrate their application in different aspects of clinical care, it is important to take a moment and share a little historical perspective on these devices. So let's do a quick review. The use of ultrasonics in dentistry was first advocated in the early 1950s as a novel method for tooth preparation. Now, however, this method never really became popular because it was not as efficient as using a high-speed handpiece to remove dentin or enamel. But a mere few years later, Zinner reported using an ultrasonic instrument to remove calculus deposits from teeth. So this technique was soon improved, and the first ultrasonic scaler became an established tool. For endodontics, ultrasonics were first introduced by Richmond in about 1957. However, it took several decades until Cunningham demonstrated the ability of ultrasonically activated K-type files to remove dentin very efficiently. Now, that was basically in the early parts of the 1980s when the term endosonics was first coined. Now, this term defined the use of ultrasonics to synergistically instrument as well as disinfect root canals simultaneously. Now, ultrasonic energy has the ability to disrupt the biofilm on the root canal walls and accelerates root disinfection when it's combined with water or a root canal disinfectant. So, what is ultrasound after all? Ultrasound is sound energy with a frequency of about 20 kilohertz. Now, 20 kilohertz is the upper limit of the human hearing. So, as a result, ultrasonics are usually inaudible to our ears. The range of frequencies that were used in the original ultrasonic units were somewhere between 25 and 40 kilohertz. Later on, lower frequency ultrasonic handpieces were developed that operated at about 1 to 8 kilohertz. That's basically in the sonic range. The lower frequency handpieces removed dentin less aggressively than the true ultrasonic devices and were favored by some people. The main problem with ultrasonics, or even these sonic range instrumentation devices, were a lack of control over the whipping action back and forth of the tip of the file that was being ultrasonically activated that could then create a ledge or some transportation in the root canal. Now, there are two basic methods of producing ultrasound. The first is through magnetorestrictive activation, which essentially converts the electromagnetic energy into mechanical energy, and the other is based on the piezoelectric principle. The magnetorestrictive devices convert electromagnetic energy into mechanical energy. Basically, in these units, a stack of magnetorestrictive metal strips that are in the handpiece are subjected to an alternating magnetic field. Now, this creates vibrations in the metal strips, and that results into ultrasound. Naturally, these vibrations create some frictional heat that should then be cooled during the operation. And as a result of that, overheating is a serious limitation with these units during their endodontic use. Now, in piezoelectric handpieces, on the other hand, you have a crystal which is used, and this crystal changes dimensions when an electrical charge is applied to it. And this deformation of the crystal is converted into mechanical oscillations and ultimately into ultrasound. Now, the result of that is that you do not get the same kind of heat that you would get with the electromagnetic devices. Now, as a result of that, you don't get the same kind of heat generated by the magnetorestrictive devices. So the newer piezoelectric units, they have some advantages basically over the older magnetorestrictive units because they offer more cycles per second, something of about 40 kilohertz versus the original 24 kilohertz. Now that makes them far more powerful. And the tips that are on these units work in a linear back and forth motion, which is a more ideal kind of a motion for endodontics. On the other hand, the magnetorestrictive units produce an elliptical figure 8 motion, which is not ideal for either non-surgical or surgical endodontic applications. Now, as I mentioned earlier, these units also get very hot and they need constant cooling, so that's also a disadvantage. Now, of course, we use ultrasonics to clean our instruments prior to sterilization, as well as some other clinical applications during practice. But the use of ultrasonics is primarily dedicated to endodontics and periodontics during clinical practice. However, some recent applications in minimally invasive dentistry, as well as in surgical bone removal, have also now become available with some specialized tips. These tips can bevel restoration margins or remove bone during surgery. In this presentation, I'm limiting the use of ultrasonics to the piezoelectric units, which are used primarily in non-surgical endodontics. Now, there are multiple piezoelectric units available on the market, and all of them do a fairly good job during endodontic therapy. In my clinic, I use the Varios 350 unit by Brasseler USA for the following reasons. Now, this unit is very small and it fits almost at the palm of one's hand. It has a fiber optic light at the tip, which helps greatly for visualization, especially if one does not have a microscope. And last but not least, this unit has the highest output power than any other unit that I've come across. So let's take a moment and look at some of the clinical applications of piezoelectric ultrasonics in endodontics. So let's review ultrasonic use in endodontics in a temporal fashion from the beginning to the end of non-surgical procedures, such as a conventional root canal therapy. Prior to the root canal procedure, the ultrasonic instrument can be used to loosen provisional restorations or permanent crowns prior to the removal. Careful application of a thick vibrating tip to an area near the crown margin without damaging the margins can help break the cement interface and loosen the crown. You can then remove the crown with your favorite crown remover or a pair of forceps. In this application, the tip functions to merely vibrate the crown and breaks the luting agent, which allows the loosening and the breaking of the bond. During access preparations, ultrasonics are used heavily, and they can be used basically to break away any attached or loose pulp stones that are found in the pulp chamber, and also finding calcified canals. Now, this is a far more effective approach than crushing the pulp stones with a drill. The action of cutting dentin is best described as a brushing action with a fairly light pressure against dentin. Pressing hard will actually reduce your cutting efficiency, and it dampens the free oscillations of the tip of the ultrasonic unit, which will then reduce your cutting efficiency. Now, the pressure required is much lighter than that which is used on a low-speed handpiece. Using ultrasonic energy, a thin layer of dentin is removed incrementally and with more control than using a low-speed handpiece. Light pressure is used during troughing dentin in search of calcified canals. The improved visibility and control that you get and the cutting action makes the ultrasonics especially ideal when searching for calcified canals. Whereas a low-speed handpiece can also effectively remove dentin. Now, the handpiece's head can invariably block the operator's field of view, and it makes searching for the calcified canals a lot more challenging. This can be very dangerous and can potentially lead to iatrogenic mishaps such as ditching, ledging, or worse yet, a perforation. Using an ultrasonic handpiece greatly improves visibility and it allows you to see the site of action. Now, with my Varios 350, I use a couple of tips that are most commonly used for finding calcified canals. One of these tips is the E15D, which is a diamond-coated ball-shaped tip that helps me explore and find calcified canals such as the MB2. This tip is approximately the size of a number 2 round burr and can effectively brush away dentin with more control. Another useful Varios tip is the E14D tip. This tip is my universal tip, and it is basically on my ultrasonic all the time throughout the procedure unless something needs to be changed. So it's the tip that I always start with and is the one that I recommend everyone to use. It is basically a universal tip, and I use it for several applications, as you will soon see. The fine diamond coating allows some cutting on the sides of the ultrasonic tip as well as the tip. And as a result, the tip can be used to refine access and it can improve the flow of files towards the canal orifice. A very useful application for ultrasonics is removal of gross debris. When combined with water, an E14D tip is the fastest way to remove the cut dentin that is present in the field immediately after access preparation. After access preparation is complete, the use of the ultrasonic and water is also an effective way to irrigate the canal in the early stages of pulpectomy. During this irrigation stage, I use the E14D tip without trying to cut dentin. Simply place the tip just into the canal orifice and then activate it. And that will give you effective irrigation for removal of gross debris quite efficiently. Now, I recommend this irrigation mode for the early phase of the pulpectomy due to its efficiency as well as the safety of avoiding sodium hypochlorite until the working length has been established. After the working length determination and the initiation of positive or negative pressure irrigation with a disinfectant, occasional activation of the irrigant with the ultrasonic will increase its efficacy. Ultrasonics can also be used for instrumentation of the root canal. The E11 and the E12 Varios tips can fit sizes 15 through 35 K-type files that can then efficiently instrument root canals. However, these straight tips are quite stiff and are not recommended for any curved canals. However, I find these tips with a size 15 file to be very useful for deep irrigation or activation of the irrigants in the root canal. These are also very helpful for removal of debris deep inside the root canal during retreatment, such as a situation in which you have some gutta percha on the canal walls or some cement that has been set, and activating these with the ultrasonic is a far better way of removing them than purely trying to dissolve them. This activation of the irrigant using ultrasonics is a function of increasing the kinetic energy of the fluid through agitation and acoustic streaming, as well as cavitation. All of these physical effects create heat, and the generated heat will actually also increase the efficacy of the irrigants. Ultrasonic energy has been shown to remove the smear layer and leave clean dentinal surfaces and tubules that can therefore create a much better irrigation and disinfection of the root canal, and also help with the final rinsing and removal of the smear layer prior to the obturation. Ultrasonics also have been used during obturation phase of treatment. Ultrasonics are effective at distributing sealer in the canal and coating the walls effectively. This can be achieved by the use of an E12 Varios tip, as well as their use for ultrasonic lateral condensation of gutta percha. Some other spreader tips are also available that can help in warming the gutta percha and allow for warm lateral condensation for people who prefer that obturation technique. Now, a little trick to use the ultrasonic is to use the tip without any water to sear off the gutta percha at the orifice. This is a useful trick if you don't have access to a proper heat source, such as the EndoPro 270, in which case you can use your ultrasonic without water to heat up the tip and sear off the gutta percha. One final use of the ultrasonics for obturation is for cleaning the sealer, especially a bioceramic sealer and the other hydrophilic sealers, out of the chamber very efficiently by the use of the same E14D tip with water for a mere 10 seconds. Special care should be paid so that you are not actually touching the gutta percha, and that you're only touching the canal walls and allow the water to wash out the cement. This is a very efficient cleaning process compared to the traditional techniques. The use of ultrasonics and endodontic retreatment is well established. Essentially, any part of the procedure that requires shattering or vibrating an object is better achieved through ultrasonic energy and activation of a tip. Therefore, these devices are truly required for endodontic retreatment cases. Not only they can help vibrate and loosen up external restorations such as crowns and temporaries and bridges and so on, they're also immensely helpful in removing intracoronal restorations such as posts. Now, the best way to remove a post is to remove all of the core buildup around the post, exposing the cement line, and then using a handpiece to create a little channel right around the post, which you can then vibrate using your ultrasonic, which will then help break that interface between the post and the dentin, which is filled with cement. The ultrasonic activation of this cement line will loosen up the cement after the cement is broken and washed out with the help of ultrasonic and water. This process requires some time, and patience is certainly required. A well-cemented post can easily take up to 20 minutes or even longer sometimes after you've started the access preparation and isolated the post and then vibrated it out. Here, patience is obviously key to improving your chances of success and avoid mistakes. Now, an important point that I'd like to mention here is that about 91% of your ultrasonic activation should actually be done in the presence of water, and it's just that the water is actually what's helping transfer the ultrasonic energy into the objects that you're trying to vibrate out. And at the same time, the ultrasonic energy used in a dry field will create a lot of heat, and this heat can easily damage the periodontal ligament and the bone as well as the supporting structures. So please use the ultrasonic with water at all time. With short interruptions during the procedure, you can cut the water flow in order to then visualize the cutting field. But make sure you put the water back on. Now, with proper protocol and intermittent dry and mostly wet ultrasonic cutting, you can remove posts, silver points, soft and most of the hard cements that are found in obturation cases around the world, and then also occasionally remove broken instruments deep inside the root canal. Ultrasonics are the most useful tool for removing broken instruments or other obstructions in the root canal. The technique requires the creation of a platform right at the level of the obstruction, followed by the use of a very thin ultrasonic tip, such as the E7 Varios tip, to gently vibrate the fragment out. It's important to understand that any attempt at removal of a broken instrument is strictly reserved for the clinicians that are using high magnification and illumination, such as an operating microscope. Any attempt at removing a broken instrument with inadequate vision and by simply placing a fine ultrasonic tip deep inside the canal will at the very best result into a ledge and at the worst create a perforation. Now, despite the manufacturer's artistic drawings of various instrument removal kits, these kits invariably require visualization of the most coronal portion of the broken instrument or the fragment that you're trying to remove, and are therefore reserved for the specialist or the microsurgeon. When the surgical ultrasonic tips were introduced to endodontics by Dr. Gary Carr in early 1990s, the entire surgical endodontic concepts changed almost overnight. As a result of this innovation, the highly beveled, off-axis, shallow retro preparations were replaced with about a 3 millimeter deep preparation in the long axis of the root canal that allowed far better seal than the previous amalgam BB gun preparations that were placed at the end of the roots. Now, one can easily claim that surgical ultrasonic tips, combined with bioceramic retrofills and a better understanding of case selection, have all dramatically improved the outcome of surgical endodontics today. The retro preparation technique using ultrasonics can be summarized in the following fashion. After cutting the apical 3 millimeter of the root tip perpendicularly to the long axis of the tooth and with minimal beveling, the ultrasonic tip is then introduced into the bony crypt and activated against the gutta percha right at the very end of the root. The tip is then gently guided along the root axis and into the root canal for up to 3 millimeters. The ultrasonic energy delivered by the tip melts and removes the gutta percha in the root canal. It's very important to use water with your ultrasonic tip at this point. If the case has had another apicoectomy, the ultrasonic tip can also effectively loosen and remove old retrofilling materials such as amalgam and so on, so that it could be replaced with a fresh one. Now, widening the root canals helps remove any of the potential biofilm or bacteria that is on the root canal surface at this time. After removing the 3mm plug of gutta percha, the retropreparation should then be disinfected with a mild, non-toxic disinfectant. A bioceramic retrofill is then placed into the canal in order to fill the retropreparation. I use a technique that I have developed that combines the injection of bioceramic sealer into the retropreparation, followed by the placement of some bioceramic putty at the cava surface area to protect the sealer during its setting time where it is susceptible to wash out. Okay, now let's quickly review a retrofilling technique I've developed that uses the bioceramic sealer and the putty. Okay, let's start by drawing a little tooth here for you. This is a tooth that has had a previous root canal, so there's a little bit of a gutta percha right inside the root. And here's our access opening. And now, when we do a retrofilling, obviously we first have to do an apicoectomy, which is the 3mm from the end of the root. It's very important to make a perpendicular cut. You know, it's almost along the root axis. Do not make a large bevel. Bevels are kind of out of favor because you expose a lot of dental tubules unnecessarily. Now, using microsurgical techniques, you can actually make a 90-degree cut for your apicoectomy that will give you better results by reducing the permeability of the dentin at the cava surface area. So let's just remove this apex here. It'd be nice if we could do the same thing clinically. Just erase the root end. No chance of popping that thing into a sinus or anything like that. So now we have our sectioned root end here. And the next step is we're going to use one of our best tips, which are these surgical tips for the Varios 350. And after using a couple of these tips, you first start by creating a little oval shaped, and then what you need to do is you need to get those little triangles right at the apical end of the retrofilling so that you can get a good preparation. And then you also have to expand the retrofilling in all directions, 360 degrees, which helps you remove dentin and remove any potential biofilm that might be left on the dental surfaces. So now you have a nice retropreparation that's ready to go. Next step is to deliver your bioceramic sealer. So I found that if you use a little acid etch tip, the same stuff that you put your phosphoric acid through, and bend it with a bird beak pliers about 90 degrees at about 3mm, it allows you to deliver the sealer nicely directly into your retropreparation. Now, it's important to realize that you need to put the tip of the acid etch, the delivery tip, all the way at the base of your retropreparation. A lot of times people put this base at the top, and then you will end up trapping a void. Then what you do is you will inject the sealer slowly as you back yourself out of the canal. What this does is it allows a nice way of depositing the sealer without trapping any air or creating any voids. So withdraw the tip slowly. Now, after you remove the tip, you end up with a little dome of sealer right at the root end. And what you need to do at this point is you get yourself a little ball of the putty, the bioceramic putty, the stuff that is like cavid. Now, originally, the technique that I developed for the retrofilling involved making a little cone out of these guys and putting it through the whole mass of the sealer. But then after playing around with this, I realized, well, what's the point of doing that? Because the sealer is good enough to seal and close that space. The only problem with the sealer is because it's runny, it could potentially wash out. So I figured, why don't we use the putty to just seal the surface of the sealer? And because the putty doesn't wash out and it's very resistant to washout, and what it does, by placing a little ball of it, it's really easy to make a tiny ball or just any fragment of it and just smear it using a little spatula right on the cava surface where the sealer dome is. And what that does is, as I mentioned, it seals the surface for you. and you can remove any excess sealer with a little micro brush. And after you do that, you can also use a little bit of, hydrocarving or a little bit of water carving, using a little bit of a water to remove any flash. Now, of course, if you leave some flash behind, it doesn't matter because the material will set, it's very biocompatible, and it will set to hydroxyapatite. So it's not a problem if you have some flash around. In fact, it's made my cleaning of the area a lot easier nowadays. So that's the essence of this little technique that I've developed, which you are using the sealer, in fact, to fill the retro preparation completely, but then you're also using the putty to seal the sealer in there for the about 3 hours or so it takes for the sealer to set. The putty is more resistant to washout, and that's the technique. Okay, now let's just see a quick clinical case here. The lower right molar, tooth number 30, was referred to me to address an infection, a periapical infection. As you can see, there's a fairly large lesion at the apex, and there's been a history of a previous root canal, and apparently there was an attempt at a retreatment once before, a year or so before this, but there is still a lesion, and apparently the retreatment didn't work either. So the question was whether I should retreat this or go to an apico. It looked like the original retreatment attempt was fairly good. They tried, but the mesiolingual canal seems to have been blocked, and therefore I decided not to put this tooth through another retreatment, but yet just try to do an apico. So I use the same technique that I just mentioned here, and here is the immediate post-op of the case. As you can see, I wasn't shy about removing bone to get down to the apex and get to that mesiolingual canal. And this is the osteotomy, the dark area that you could see here. And the retropreps and retrofills were done with this exact technique that I just mentioned. So it's BC sealer at the apical area and then just a smear of putty right at the top. And you can see that it's fairly dense and there are no voids in there. If you can get the base of your applicator tip all the way down to the bottom of the retroprep and then slowly back up, you're not going to trap any air. It does require a little bit of a practice, which you could do on extracted teeth. So this was immediate post-op, and here you can see this is the post-op exactly 1 year to date of the apicoectomy, and the patient is completely asymptomatic, and you can see this tremendous healing in 1 year. As you saw in the immediate post-op, I did not use any kind of a bone fill. I normally do not use it. Endodontic lesions are 5-wall defects, and there's usually no need for any grafting or membranes when they are only confined to the apex. And so, but a year later, you can see there's complete healing of the apical area, and the patient is asymptomatic. So this just goes to show that this technique works very nicely and is a very simple and easy technique. The total time for the retrofilling of these 4 roots and this molar was probably about a minute or 2. That's all, because each retrofill is no longer really than 10 seconds. All right. Now, a good case selection and sound operating technique will give you a highly predictable outcome using microsurgical techniques for apicoectomy. Bone removal during the surgical treatment is also possible using ultrasonics, but higher models are required than the regular Varios 350. Lastly, I'd like to cover some of the tips that I use with my Varios 350 ultrasonic unit by Brasseler USA on a technique card that is called the chairside technique card. So let's go over some of these tips. Okay, let's go over some of these tips that I've mentioned over the presentation. Now, Brasseler has a little bit of a chairside endodontic tip card. It's a little bit of a cheat sheet that you could use to get an idea about what each of their tips can do and what kind of setting it can be used in. So let's just go over each tip a little bit and discuss it. The first one here you can see here on the left is the E4. E4 is a great all-around tip as well, just like the E14 dip, which as I mentioned, a tip that I mentioned to you earlier, is my most favorite tip. It has a lot of functionality. E4 is thinner, it's not diamond coated, and by the way, whenever you see a D here next to the tip, that means that it's diamond coated. When it doesn't have a D, then it means that it is a plain tip. The E4 is great for general
purpose acoustic streaming. It's good for irrigation and so on. But I found that the E14D can be used also for your irrigation acoustic streaming, as well as some of the troughing and preparing your access preparation, finding canals, and basically an all-around nice tip. Now, the E9D and the E9 are also great tips. They're pretty much, they're much thicker than the E14. They're the same shape as the E14, except that they are much thicker. They're quite a workhorse, and they're very efficient in terms of their cutting. The D especially is pretty coarse and does a great job troughing dentin. As I mentioned earlier, also, the E15D is a nice little ball-shaped tip that is about a size number 2 round burr. So this tip is great for finding canals, MB2s, as well as calcified canals, and it can efficiently and very conservatively get in there and find your canal. These two tips, E11 and E12, are file holder tips. Now you get these little file inserts that have sizes 15 through 35. They're fairly stiff, but they are great to use for efficiently removing dentin. And as I mentioned earlier in the presentation, I also use the size 15 tip for irrigation and activating my irrigant. They're great tips. And the CR10 is just it's a little bit of a wrench that has a over-torquing safety feature, so that you can never over-torque or too tight and tighten these tips too hard. You can see here that they have some of the indications for some of the tips along with the tip name on the right side. Now on the second page, so here we are now on the second page, and in the second page they have now some of the surgical as well as some of the other specialty type of tips. On the left side you see again the E15, which is the same as the E15D without the diamond coated tip. Now this little round tip is great for vibrating posts. The E16D, E17, 18, and 19D are also pretty thick and strong ultrasonic tips that have a myriad of uses, especially again for vibrating posts and other instruments that are fairly thick and strong that have been cemented into the tooth. E20, 21, and 22 are thin diamond, not diamond, they're non-diamond coated, but these tips are titanium tips, pretty stiff. There's not too much amplitude of motion going on, and they're great for removing your broken instruments and smaller or obstructions that may be deeper inside the canal. Now on the right side here, the best Brasseler's endo surgery tips are really great for your apicoectomies. And the 1D, 2D, 3D, 4D, 5D, and 6D are the way they're numbered. The 1D and the 2D are the universal tips. You always end up using pretty much the 1D first, which is about a 0.5 millimeter in diameter, and it's 3 millimeters thick. And what it does is it pilots a little hole in the middle of your gutta percha. Then you follow it with the 2D, which will make your preparation a little bit wider. In the process, remove any gutta percha on the walls, as well as widen the dentin and remove any smear layer. The other sizes, 3D, 4D, 5D, and 6D, are just different angles right at the tip and at the shank here that allows you to get into different configurations and shapes of roots deeper into the tooth. For example, a lower molar on the right side and the left side, using depending on the side that you're in. And they have included here a little bit of a working zone and the a little again another graphic here about which teeth you're going to be using which tip in. So just a brief review of all of these tips. You saw some of the applications during the presentation, and you can always go to this little sheet and look at them and read each tip's detail usage and measurements all in here on this tip sheet.
Well, I think this covers it all. In conclusion, ultrasonics were first introduced to endodontics over 50 years ago. Since their early introduction, they have come a long way, and today's units are small, powerful, and versatile. And they have a number of tips that can cut, dentin, and activate your irrigants, as well as removing your posts for you, and also removing canal obstructions, as well as many, many other applications. I use my ultrasonic unit one way or another on almost 100% of surgical and non-surgical cases that I do clinically. It is the one indispensable endodontic device that I'm thankful for its many ways that it helps improve my case outcome and clinical efficiency as well as efficacy on daily basis. Please visit our website, Real World Endo, and share your own experiences with our faculty and the global community at large. I look forward to your participation. For Real World Endo, I'm Ali Nasseh, and I hope you found this presentation helpful.